Thank you so much for being here. I'm sorry that we're a little bit running late, but as your presentation, I'm sure it's going to be just as great. So I'm so excited for you being here. So thank you, everybody. Let's go ahead and welcome Dr. O'Brien out of Ohio. Thank you so much for being here.
Oh, you're welcome. Thank you for the invitation. It's my pleasure to be part of the medical symposium today. And I know we also have some patients and families on the line. So hopefully there's something useful for everybody in this presentation. And Dr. Martin really teed me up very nicely because she already pointed out the importance of recognizing women who are living with bleeding disorders in addition to our male patients. So I'm going to try to cover a lot of different topics in the next 45 minutes or so. My name is Dr. Sarah O'Brien. I am also a pediatric hematologist. I work at Nationwide Children's Hospital, which is in Columbus, Ohio. And my practice really focuses on the intersection between women's health and hematology. So I see a lot of women with heavy menstrual bleeding and women who are living with bleeding disorders and women with iron deficiency. So some of the things I'd like to talk about today. One, we're going to talk about, and I'm so thrilled that HFA is really bringing attention to this simple statement that women with hemophilia do bleed. And we're going to talk about increasing awareness of that fact. And then we're going to back up a little bit and talk about when we're meeting patients for the first time who are complaining of bleeding symptoms, what kind of clues might there be in the history that suggests we need to think about a bleeding disorder for those patients? Then we're going to talk about some of the treatment options available for heavy menstrual bleeding in women and girls with all types of bleeding disorders. And we're not going to go into detail there, but I want you to come away with the knowledge that there's so many options available for our patients. We're going to remember the importance of iron deficiency in women with bleeding disorders. And then just because it's such a common question from our non-hematology colleagues, I'm going to talk a little bit about laboratory testing. So I wanted to start off with a patient case today. And this is a patient that was referred to our Young Women's Hematology Clinic a few years ago. At the time, she was 12 years old and she was being referred to me because of heavy menstrual bleeding, which she certainly did have when we took a detailed history. She came to the visit with her mom, who also had a history of heavy menses. Mom had had 2 children and had also experienced heavy postpartum bleeding with both of those deliveries. There was also a maternal grandfather who had mild hemophilia. He was not followed in our HTC system, but at a private hemonc group in town. What I found so fascinating about this visit is that this bullet point number 4 did not come up in the referral or in the initial conversation. It wasn't until I specifically asked, does anybody in the family have a bleeding disorder, that this information came up. And that's because it had honestly never occurred to mom that her family history of hemophilia had anything to do with her symptoms or her daughter's symptoms. We started a laboratory evaluation and found that her factor VIII level was 53%, which would be a normal but low normal factor VIII level. We then proceeded with genetic testing, which demonstrated a variant of unknown significance in the factor VIII gene. So then I wanted to test grandfather, of course, but grandfather's hematologist told him that there was no way his granddaughter's bleeding was related to the grandfather's hemophilia, and that I, meaning me, was barking up the wrong tree here. So mom had a few conversations with her dad, and eventually he agreed to come to our hospital to get testing. And he was found to have the same exact difference in his factor VIII gene as his granddaughter. And so now we know that that factor VIII gene variant is one of significance in that family, of course. So I love this case. One, because my patient is now on treatment and doing fantastic, but also because it just shows that the lack of awareness, both within families, within the medical community, and how we really have so much work to do to learn more about women and girls with hemophilia. And I think even this terminology has changed, honestly, in the years since I've been practicing hematology. And we're moving less away from calling everybody carriers and calling women who have bleeding issues, women and girls with hemophilia, because it's a bleeding disorder, just like all of the other bleeding disorders that we take care of. So let's get into the data a little bit that shows us that it's not just my patient or patients here and there, but we have studies now that clearly show that women who are carriers of the hemophilia gene are more prone to bleeding. So one study I wanted to highlight is from a global emerging hemostasis panel, and this is a group of collaborators from several different countries across the world, as you can see. And what this study did was compare mean bleeding scores in hemophilia carriers as compared to healthy women. And the ISTH bleeding assessment tool, or ISTH BAT score, is one that we commonly use in hematology. We ask 14 questions about different bleeding symptoms, and patients get different scores depending on how severe the bleeding symptom was. So just to put this into perspective for you, when in normal patients, a bleeding score for adult women is considered 5 or less. That's normal. In this study, you can see that the carriers had a mean score of 5.7. So not only were their scores much higher than the control women in that population, but their mean score was even higher than what we consider to be at the top of the normal range. So, and the most commonly reported symptoms in this study were heavy menses, oral cavity bleeding, postpartum hemorrhage, and excessive bleeding after tooth extraction. This study was one performed in the United States, and in this one was comparing hemophilia A carriers, so factor VIII deficiency carriers, to, again, normal control females. And you can see that across the board, the bars in blue, the hemophilia carriers, are much higher than the bars in red. So they were much more likely to have these bleeding symptoms. So in addition to the symptoms that we already mentioned on the last slide, here you can see that cutaneous bleeding, meaning bruising, epistaxis, meaning nosebleeds, and post-surgical bleeding were also commonly reported. So we know that these women have increased bleeding issues. Let's talk about joint bleeding for a little bit, because of course that's the hallmark bleeding symptom for males with hemophilia. And it's been established for a long time that women who have severe factor VIII or factor IX deficiency, which Dr. Martin was reviewing how that can happen, and it's a very rare finding when women have very low levels, but we've known for a long time that those women do experience joint bleeding similarly to males of the same factor VIII level. But what we're learning more recently is that joint bleeding appears to affect a much broader portion of the carrier community than we had previously recognized, with frequencies ranging from 4 to 19% of women, depending on the study. We're also learning that women with hemophilia can also experience subclinical joint bleeding. So maybe they've never had a joint bleed like what they are familiar with their brother or their son, but studies show that they have decreased joint range of motion as compared to healthy controls. And in one very small, but I think very important study, Dr. Sidonio looked at 9 carriers with decreased range of motion who agreed to undergo joint MRIs as part of this study. And across the board, osteochondral changes, meaning changes in the bone, were found, suggesting that these women, in fact, had been having small microbleeds over time. So I think as we begin to see women who are carriers, women with hemophilia, when they are complaining of joint issues, we need to think about, not just the usual things we think about, but could microbleeding be part of the picture here? What makes this so challenging for us as providers is that in women, the link between factor level and bleeding is inconsistent. When we meet a family who has a new baby boy with hemophilia, when we learn whether that baby boy has a level of less than 1%, a level of 4%, or a level of 40%, we can give that family a little bit of an idea of what type of bleeding that their son may experience. We don't have that crystal ball in women. This study is again looking at that global panel that I mentioned before from several different countries. And this graph is showing us factor level on the x-axis. So the factor level is getting higher. And here's the bleeding score on the y-axis, and the bleeding score is getting higher, meaning you have more bleeding. So remember that we mentioned that 5 is considered the upper limit of a normal bleeding score. So in a perfect world, what you would expect is that as the bleeding score gets very low, as that factor level gets very low, that the bleeding score would get very high, and vice versa, that as the factor level is normal, the bleeding scores are low. But you can see there's a little bit of that pattern here, but we definitely have women over here who have very low factor levels, but do not have a lot of bleeding. And we have women over here who have normal factor levels, but lots of bleeding. So we can't just go by the factor level. We can't see young girls and say, oh, you have a normal factor level, you're never going to have a problem. That's simply just not true. This study shows us that even in the same family, you can't predict what's going to happen. This is a large Amish pedigree of patients with hemophilia B. So they all have the exact same mutation. And you can see that even in this large family, you have factor IX levels ranging all the way from 19% to 114%. And you have bleeding scores ranging all the way from 1 to 8. Here we're looking at how bleeding symptoms in women change across the lifespan. And this slide would be applicable not only to women living with hemophilia, but women with the other bleeding disorders that we take care of, most commonly von Willebrand disease, platelet function defect, rare factor deficiencies. And this comes from an educational program I participated in from the Core 2 Ed group. And here's the link here. There's some great short videos on when recognizing women with bleeding disorders and initial management. It's geared towards healthcare providers. So in childhood, we're most likely to see easy bruising, nosebleeds, or we may be seeing very young patients who have never bled but have a family history of bleeding. As we move into adolescence, this is when we begin to see patients presenting with heavy menstrual bleeding or bleeding after tooth extractions. This is when people are getting braces and need their teeth pulled before braces, or they're getting their wisdom teeth out. Then we move into adulthood when women are starting to have their families and they may be experiencing postpartum hemorrhage. Certainly surgeries are another cause of bleeding in adults. As women near menopause, heavy menstrual bleeding may recur, and we'll talk about that a little later in the talk. And then in late adulthood, again, surgical bleeding we see, and bleeding from gastrointestinal sources becomes more common. So we've focused on women with hemophilia so far. Like I said, now I want to take a step back and let's talk about when patients come to us with bleeding, how do we separate normal bleeding versus bleeding that may be suggestive of a bleeding disorder? And I'm going to focus on the 3 symptoms that we most commonly see, which is bruising, nosebleeds, and heavy menses. The reason why this is so challenging for healthcare providers is because mild bleeding is common in patients with bleeding disorders, but also in patients without bleeding disorders. And this is a study of 500 completely healthy adult patients. And you can see that even in this healthy population, A quarter of them reported nosebleeds. Almost half of the women reported that they had had heavy menses at one point, and symptoms such as bruising, blood in the stool, and bleeding after tooth extraction were quite common. When we meet a patient who's complaining or concerned about bruising, we talk about the level of trauma that they're experiencing. So do they tend to see bruising when they feel like they barely bump themselves, or they'll wake up with a bruise and have no idea how it even got there? That would be suspicious. The site of the bruise can also be informative. We're most likely to bruise our forearms, our shins, our hips, because that's where we're bumping into tables and the corner of the file cabinets and things. I'm a pediatrician, so I also have to mention that, of course, forehead bruising is very common in our population as toddlers begin to explore coffee tables and such. But when people are having bruising on their back, on their trunk, that's a little more unusual, and it makes us raise our eyebrows a bit. The rule of 5 is also one that I'll ask patients. Patients who tend to have 5 or more bruises at any one time are more likely to have an underlying bleeding disorder. Those are some clues that you can ask in your history. Another common symptom that we see, of course, is nosebleeds. And I already mentioned that 25% of healthy adults report nosebleeds, 39% of healthy children report nosebleeds. And of course, in patients with bleeding disorders, this study was looking at von Willebrand disease. Over half of those patients may experience nosebleeds. And actually, it's less likely for our patients to have those really severe nosebleeds where they end up in the emergency room and have to go to the OR to be cauterized. That can happen, but our patients are much more likely to have these recurrent episodes of benign epistaxis. They wake up in the morning and can tell they had a nosebleed from their pillowcase. Then they have another nosebleed at school, then another one that night, and they just can't seem to get that nosebleed under control. It's also important for us to recognize as providers that nosebleeds change over time. So nosebleeds are very common in children, but in children with and those without bleeding disorders, nosebleeds get better over time. And it's unusual for someone over 14 to develop new nosebleeds. So for me, as someone who takes care primarily of adolescents, I have to remember that. If I ask my patients if they had nosebleeds, they're going to say no. I have to say, what about elementary school? Did you ever have nosebleeds then? Mom, do you remember her ever having nosebleeds in elementary school? And that's when you hear the story about the school playground and, oh yes, and that was a big pain, but now it doesn't happen anymore. And then again, epistaxis becomes common again in older adults. And we think that's because many older adults use daily aspirin for cardiovascular protection, but that places them more at risk of nosebleeds. Or high blood pressure can also make you more prone to nosebleeds. So it's kind of common in childhood, then dies down in adolescence, and then older adults, you'll see it more. This is a study that was performed in a pediatric population, but I think it's also applicable to the adult world. And this was a study looking at patients who all had issues with nosebleeds, but looking to see kind of the difference between those nosebleeds. And the column in the middle are patients who were tested and found not to have a bleeding disorder. And the patients on the right were those who went on to become diagnosed with von Willebrand disease. So you can see that as compared to the control subjects, patients with von Willebrand were more likely to have sought medical attention for nosebleeds. They were more likely to have more than 5 episodes a year. So that's why I talk about the rule of 5. So I already told you to ask your patients if they have more than 5 bruises at any more time. Also ask if they tend to have more than 5 nosebleeds in a year. A nosebleed lasting more than 10 minutes is suggestive of a bleeding disorder. Nosebleeds that occur from both sides is more suggestive of a bleeding disorder. On the flip side, if your patient can clearly correlate their nosebleed to seasonal allergies, dry air in winter, then that's less likely that they have a bleeding disorder. So we've talked about bruising and nosebleeds. Let's talk about reproductive bleeding. And we're going to talk about reproductive bleeding a lot in this session because we're focusing on women with bleeding disorders. So these are some red flags that you should note when you're taking a menstrual history. This is from Project Red Flag, which was an initiative that the National Hemophilia Foundation did a while ago now when they were first trying to bring attention to the issue of women's bleeding. So I teach this to medical students all the time. I also teach this to, I will often do kind of a pre-menarche visit with my families with bleeding disorders. So when my patient is 10 or 11 and the family's thinking that periods may be starting soon, this is so helpful to sit down and talk about what's normal, what's abnormal, when do we want you to call us? Here's what we're going to do if there's a problem. And that can be, for families who are listening, I really advocate that you do that for the women in your family. I think it relieves a lot of anxiety. So let's go over those red flags. Menses lasting more than 7 days is unusual. Having to soak a product more than 4 to 5 times a day is unusual. In today's world, as doctors and nurses, we have to get very detailed with products. There are so many products on the market now. There are ultra tampons, there are overnight pads, there are period panties. So you really need to find out what your patient is wearing, because if they are wearing an adult diaper during the day, they're not going to need to change that every 4 to 5 times a day, but that's still an issue that they're needing to wear that. So we have to get very detailed. Requiring double protection, needing to wear a tampon and a pad at the same time to prevent leaking. Having to get up at night to change your product is unusual. Experiencing gushing. So I will ask patients, when you get up to go to your next class at school, when you get up at work to go to the restroom, can you feel your menstrual flow coming out? And then passing large clots is unusual. And any clot greater than the size of a quarter would be one that would be considered unusual. Now, this is very nitty-gritty information, but this is really important because women don't talk about these things to each other. And women in the same family with a bleeding disorder, they may think their periods are normal because they're all having the same kind of period. So you really need to get detailed on the line between normal and abnormal. This was a guidelines from an expert panel from 2009. Many of these are similar to the red flags we just discussed, but I'll also point out other few clues that may make you think of a bleeding disorder. Are they failing to respond to your first line treatment for heavy menses? Have they been having heavy menses since menarche? Are they having iron deficiency or anemia? Do they have other bleeding symptoms? Do they have a family history of bleeding symptoms? All of those are clues that we should be looking for a bleeding disorder. I also wanted to touch on anovulatory bleeding for a moment because I think that this is a reason that many women get missed as having a bleeding disorder. So anovulatory bleeding is a very common cause of heavy menstrual bleeding in teenagers, and it's due to immaturity of the hypothalamic pituitary ovarian axis. I explain this to my patients and families as it takes the hormones in our brain a year or two to figure out how to talk to the hormones in our pelvis when we're starting to have menstrual bleeding. And so what happens during that first year to two when the hormones are learning to talk to each other is that you can have irregular cycles. And these menses can range from light to quite heavy. But it's also important to remember that heavy menses can be multifactorial, and our women with bleeding disorders also experience anovulatory bleeding. When we do studies of women with bleeding disorders looking back at their reproductive years, it's very common for them to say that their heavy menstrual bleeding was at its worst right after they started having periods, and then again as they were approaching menopause. So we cannot dismiss anovulatory bleeding. So it's important to remember that even if your patient has a history that's spot on for anovulatory bleeding, if they're not responding to therapy, if they've developed iron deficiency or anemia, or they have other symptoms or a family history of bleeding, that patient still requires a laboratory evaluation up front. You don't want to wait and see for a year or two for that patient before making sure they don't have a bleeding disorder. And then anovulatory bleeding occurs again as we approach menopause. I say that's when the hormones in our brain get tired of talking to the hormones in our pelvis. But again, women with bleeding disorders are going to have an increased risk of this happening. But at this life stage, other things become common as well, like fibroids, polyps, endometrial hyperplasia, or even endometrial cancer. So I just told you that in anovulatory bleeding in teenagers, we have to look for bleeding disorders. Now, on the flip side, I'm going to remind you that even in a woman with an established bleeding disorder, if she is later in life and having new excessive bleeding, we need to rule out those structural causes. We can't just assume it's because she's a hemophilia carrier or because she has von Willebrand that she's experiencing this issue. Next, I want to move into some of the common strategies that we use to manage reproductive bleeding. And this is mainly going to focus on heavy menstrual bleeding, and then we'll touch at the end on postpartum bleeding in this section. Combination hormonal contraceptives are the most common medication that we use. Many people are familiar with birth control pills, of course, but they also come in a patch and a vaginal ring formulation. All of these work by thinning the endometrium, the lining of the uterus, and that in turn reduces menstrual blood loss. These medications have great other side effects as well, like regulating your menstrual cycle, reducing menstrual cramps, and for my patients in particular, improving acne. One thing I want to make sure that healthcare providers and families know is that there's certain type of pills we want to use in our patients. We want them to be on what we call the standard monophasic low dose pill, which typically contains 30 to 35 micrograms of estrogen. So I tell my families, I want you on one like up here. Everything's the same color for 3 weeks. These pills at the bottom are fancy triphasic pills that are supposed to more closely mimic the hormonal fluctuations during the menstrual cycle. These are not good for our patients. They are going to break through bleed on these. Another common problem that I see is when healthcare providers are seeing a teenager, they are very likely to start them on an ultra low dose pill. And I think the thinking is they're young, they want to start them on an extremely low dose. But for a woman with a bleeding disorder, again, they're just going to break right through that. So a lot of times when we're seeing patients for the first time, just from flipping them from the pill on the bottom to the pill on the top, we can make a big difference for that patient. So another thing that I want families to make sure to advocate for is that they're receiving the right type of medication. And if you or your daughter is not responding to the medication, don't give up hope. There are a bunch of birth control pills on the market, and we can find one that works better. We are using more and more IUDs for women with bleeding disorders, even in my teenage population. In general, these are more effective than the oral medications in treating heavy menses. Close follow-up is important for a few reasons. All women will have irregular bleeding for 4 to 6 months after having an IUD placed. And usually for most women, that's just kind of some nuisance spotting bleeding. But women with bleeding disorders, this may be more troublesome, and they may need an extra medication during this time. So for example, if I have a patient who's on a hormone pill and would like to switch to an IUD, we will often keep them on their pill for a few months after we place the IUD, just to help prevent them from having that heavy breakthrough bleeding. There's also very small studies. We need so much more data here, but there is some evidence that women with bleeding disorders may have an increased risk of expulsion, meaning the IUD comes out. That has happened to a handful of my patients. In all cases, they've had the IUD replaced and had smooth sailing from there. But again, you don't want to place the IUD and not be in close contact with the family. They need some more close follow-up. These are long conversations. There's so many misperception urban legends, myths when it comes to IUDs. And you really have to, what are you scared of? What have you seen on Instagram? Whose uterus exploded because they got an IUD? And just talk with them about these misperceptions and urban myths. Some of the most common ones I see, and again, I'm seeing young women, is that girls worry that they're not going to be a virgin anymore if they have an IUD. You have to explain that that's not the case. People think they can only get an IUD if they're having sex. Mothers worry that it's going to affect their daughter's fertility. People worry that IUDs should not be placed unless you've had a baby, or that even if you're done having babies. So you have to have a long conversation about the safety of this medication, how well it works, that it does not affect fertility, that it doesn't cause infection like the IUDs in the 1970s may have. It's just a whole different world. I also wanted to touch briefly on progestin-only options. These are important for patients who have migraine with aura, for example, who can't use estrogen, or maybe somebody had a side effect with estrogen that they didn't like. Maybe they also have a family history of blood clots, and so they're trying to avoid estrogen. So just talk about them briefly. A lot of times people will use this mini pill, the progestin mini pill. Not one of my favorites. You have to take it at the same time every day for it to work well. And that's common for any patient. That's difficult for any patient, particularly teenagers. We're using a lot more norethindrone in our practice. The brand name for this is Agestin. This is a great pill that just shuts down the menses. And this is great for our patients who are anemic, so we can get them to just stop bleeding until the anemia has resolved. It's also a common medication we will use for our patients who are having breakthrough bleeding in those first few months after IUD placement. We'll put them on a low dose of this, which really helps to avoid that for the first few months. Weight gain and moodiness are both common, especially at higher doses, so you have to watch out for that. Depo-Provera is another common medication used for heavy menses. When thinking about bleeding disorders, I just wanted to give you a tip that you can reduce the time frame between depo dosing. So for women who are using depo for contraceptive purposes, they will go to the doctor every 13 weeks to get their shot. But it's safe to give it a little sooner. So for my patients with bleeding disorders who use Depo-Provera, I always ask them, are you bleeding before the shot is due? If they're having a lot of breakthrough bleed, if they're getting it every 13 weeks and they're having a lot of bleeding 7 to 10 days before they're due for their shot, we can just move that up to an 11 to 12 week shot, and that takes care of all of those problems. So just keep that in mind, that it's safe to give it a little bit early. The progestin-only implantable is a small rod that's inserted into the upper arm. Great choice for long-term contraception, not a good choice for women with bleeding disorders. So that's the main point I want to make here. When we're meeting patients for the first time who have had one of these placed, usually we have to get it removed before we can even get a handle on their heavy menstrual bleeding. So definitely, it's why it's at the bottom of the slide here, not the first choice. So that was kind of a whirlwind of hormonal options for menstrual bleeding, which would be the first line therapy. But I also wanted to mention antifibrinolytics. These are non-hormonal medications that promote healthy blood clot stabilization. They're best used in the setting of regular menses. So patients who are experiencing bleeding, every 4 to 6 weeks will be a good choice for this. The one that we most commonly use is tranexamic acid, and it's 2 tablets 3 times a day, and you take it during the first 5 days of menses. It's generally very well tolerated, although the 3 times per day dosing is definitely challenging. Studies show that taking it twice a day works almost as well. Aminocaproic acid is available as a liquid. So I have used that for some of my younger patients who can't swallow pills at all, or who have trouble swallowing tranexamic acid, because it's not the world's smallest pill. So when do we use this? This is a great choice for, I talked about that period planning visit that I do with my patients. So we will have this medication at home for them. So that way, if they call us with any of those warning signs that they are worried that their daughter is having a heavy period, if we agree, they already have a medication in their cabinet to just get out and start using. So it's a great choice also for young patients who maybe they're not on any other medications. They don't want to commit to having to remember to take an oral contraceptive pill every day. Or maybe the family has some concerns about their daughter being on a birth control pill. So this is a great starter choice. It's also a great medication for women with bleeding disorders who are ready to start having children. So they don't want to be on a hormonal medication to prevent pregnancy, but we still don't want them suffering with heavy menstrual bleeding while they are trying to conceive. Many times we will see patients who have been referred to hematology and they still haven't been started on treatment because the referring doctor is worried about messing up the lab results. And we'll talk about that a little bit later. But again, this is a great choice that you could use that won't affect any of the hemostatic labs that we do in hematology. So a lot of different uses for tranexamic acid. Before leaving this section, I wanted to, like I said, just touch on postpartum hemorrhage. So this is common in healthy women, but it's even more common in women living with bleeding disorders. Up to 7 to 10% of women will experience this complication. So just as Dr. Martin was making the important point that women with bleeding disorders need to get involved early with their hematologist when they're pregnant, so that we can help guide the management during pregnancy and delivery. It's hard to find adult hematologists outside of academic settings, and we want our patients to be able to deliver at their local hospital where they're comfortable and close to family, but there's not likely going to be an expert in bleeding disorders at those smaller hospitals. So you need to get us involved early so that we can communicate with our colleagues at your hospital and have a plan in place. The plan will be different for every woman, of course. Just in general, for our women with hemophilia, for our women with von Willebrand disease, we want their factor levels to be above 50% at the time of delivery. I just talked about how wonderful tranexamic acid is. We use this a lot after pregnancy. We'll send our patients home on this to avoid extra postpartum bleeding. A lot of times NSAIDs are prescribed for pain relief after childbirth. We don't want our patients taking ibuprofen. That could increase their postpartum bleeding. There is an NSAID called celecoxib, or Celebrex is the brand name. That's the one we like to use because it doesn't inhibit platelet function like the other NSAIDs. The other important thing is that most women are seen 6 weeks after they deliver their baby by their OB-GYN. We want our patients to be seen much earlier, like at 2 weeks. So you can see that there's a lot of things that your hematologist can help with before the baby is born. Communicating with your OB-GYN, communicating with the anesthesiologist. We don't want you not to get that epidural that you want because there wasn't a plan in place for how to safely get it. We want you to have your tranexamic acid ready to go when you're at home. We want you to have what pain control makes the most sense for you and have that early postpartum visit lined up. And my last 2 sections are very brief. We're going to talk about iron deficiency and labs, and then I'm happy to answer some questions. So iron deficiency is commonly found in women with reproductive bleeding. And iron deficiency with and without anemia can both cause symptoms. And I think that point is missed a lot, so I want to emphasize that here. Symptoms of iron deficiency include fatigue, shortness of breath with stairs or physical activity, headache, feeling dizzy, especially when you're standing up after sitting for a while, cold hands and feet. Patients will chew ice or chew other unusual things like towels or books when they get very iron deficient. And I take care of a lot of athletes, and they definitely notice a decrease in their performance and endurance when they become iron deficient. So again, these symptoms will all get worse as anemia develops, but even iron deficiency without anemia can cause some of these symptoms, particularly fatigue. The World Health Organization came out with some additional guidance on iron deficiency this year. And important points I want to highlight is that ferritin is the best way to measure iron status in our patients. Ferritin, an iron level just kind of tells you like what your iron level was that day, and that depends a lot on what you had to eat. And whereas the ferritin gives us an idea of what's your iron status been for the last few months. So for healthcare providers, I draw an analogy to diabetes. That glucose level tells you what your patient's glucose is right now. That hemoglobin A1C tells you what their status has been like in the long term. So for patients, I always tell them to advocate, but make sure your primary care doctors are checking your ferritin level. And a ferritin less than 15 is considered iron deficiency. And I want people to know that because you often can't tell that from your laboratory's reference range, because so many people are walking out there with crummy iron stores that it brings down the reference range. So at my lab at Nationwide, for example, the reference range goes all the way down to a ferritin of 6. But all of my patients with ferritins of 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, they all have iron deficiency. They're just in the reference range. So that's an important point to recognize. Another thing to know is that new data is showing us is that less is more when it comes to iron supplementation. So before, healthcare providers used to put patients with severe iron deficiency or anemia on twice daily or even 3 times daily iron supplements. What we've learned is that even in the setting of severe anemia, once a day is better. And that's for 2 reasons. One is because oral iron is often poorly tolerated. Patients will get nausea, abdominal pain, constipation. If you can reduce that iron dosing, that will make these side effects much better. And then your patients will take the iron supplements rather than just keeping it on their shelf. The other reason is that when we take oral iron, it raises a protein called hepcidin, which signals to our body that we have enough iron. So if we're taking iron 2 or 3 times a day, we're constantly sending this confusing signal to our gut that we have good iron stores on board. And so it reduces the gut's ability to absorb the iron that our patient is taking. So if you take it once a day or every other day, that will reduce this hepcidin spiking. So that's definitely the way to go now. And finally, let's touch on lab testing. So I hope I've hammered the point home that when you're seeing a patient with bleeding, you want to check their CBC to make sure they're not anemic. You want to make sure their platelet count is normal, but you also want to check their ferritin level and make sure they're not iron deficient. When we're thinking about testing for a bleeding disorder, we look at the PT and the PTT to look at some clotting factor deficiencies. We do specific testing looking for von Willebrand disease. The PFA 100 is a test that screens for both von Willebrand disease and platelet function defects. And then looking at the fibrinogen or thrombin time will give you a sense of whether the patient has a fibrinogen problem. So this box on the left is kind of what we would use as our first tier testing. And then if that comes back normal, but we're still suspicious, then we move on to the second tier, and that's when we'll do some more specialized von Willebrand testing. We'll do platelet aggregation studies, platelet electron microscopy to look in more detail for platelet function defects, or we will look for coagulant factor assays, factor 9, factor 11, factor 12, factor 13. A point I want to make to the healthcare providers in the room is that it is okay to refer to your hematology colleagues if your patient's labs are normal, or even without checking their bleeding disorder labs first. And that's for a few reasons. One, you may be practicing somewhere where you don't have easy access to coagulation labs, or maybe your hospital sends their von Willebrand testing to the Mayo Clinic or LabCorp or ARUP, which are all fantastic labs, but so many things can happen to that test tube by the time it gets from your office to AREP or LabCorp that you may get a falsely positive or negative level. Also, these labs are not easy to interpret. Was the patient anemic at the time? Were they on birth control pills at the time? Had they been sick recently? And as hematologists, that's what we're trained to do, is kind of think of all of those things as we're looking at the labs. We talked a lot at the beginning of this session of how women with hemophilia may have normal labs. I have another patient with a woman with hemophilia. She's the first patient in her family with hemophilia. So it wasn't until we checked her factor VIII level that we saw that she was low. But the patient I described to you at the beginning has a normal factor VIII level. We also have patients who bleed because of joint hypermobility. They have normal labs. And we also take care of patients with that we call bleeders of unknown cause. And I tell those families that we know you have a bleeding disorder. We're just not smart enough to figure out exactly what it is. But that doesn't mean that their bleeding symptoms don't require treatment. And that doesn't mean that they don't require special precautions when they have surgery or are delivering babies. So if your patient is bleeding, feel free to refer them to us regardless of what the labs show. I also want to emphasize that it's okay and important to start treatment before the hematology appointment. I feel terrible when I see a new teenager and they've seen their primary care doctor and then the gynecologist and then me, and it's been months and they're still not on any treatment. So first-line treatment for heavy menstrual bleeding is the same for all women with bleeding disorders. So don't hesitate to start therapy to avoid continued or recurrent bleeding symptoms. We can interpret their labs even if they're on a birth control pill. Or you could start tranexamic acid, which won't affect anything and doesn't commit the patient to a long-term treatment plan. It's something they can use for a month or two while they're waiting to get in to see us. So tranexamic acid, making sure they're not iron deficient, starting oral iron, those are all really important things that you can do to set your patients up on a great path while they're waiting for their specialist appointment. And finally, I just wanted to take the time to thank HFA for bringing attention to women with bleeding. And I want to thank all of you who took time from your Saturday to learn more about women with bleeding. And I appreciate the time and interest, and I'm happy to take some questions. Thank you.
Okay, Wendy, if you want to unmute and ask your question, if that's why you're raising your hand.
Yeah, so I just have a question. I am a carrier, and when my son was diagnosed, 12 plus years ago, I got my levels tested a couple years after he was born, and I was at like 40%. So I went back to a hematologist a couple years ago, had my levels retested, and I was at like 60%. And the hematologist said that that was normal and that I wasn't considered to have any type of bleeding disorder. So I was just wondering, is that really true that your numbers can just go up and down? And if that is, then how come sometimes my levels are lower than they were when they got tested?
Sure, those are actually two great questions. So I would say that the first great question is, can levels go up and down? And definitely yes. So when it's kind of a natural evolutionary response, right? If you're in a flight or fight mode, you want your clotting factors to go up so that you're less prone to bleeding. So our factor levels go up with stress. So they've done studies showing it for von Willebrand disease, for example, that even exercise, recent illness, all of those things for women, even the time we are in our menstrual cycle affects where our clotting factors are. So definitely there's not a huge difference between 40 and 60, and that could definitely have been related to recent illness or recent activity. During pregnancy, von Willebrand levels and factor VIII levels will also go up during pregnancy and then come back down after the baby is delivered. So you could definitely get different levels, not hugely different, but the range that you're talking about would definitely be something we see. Your second question is what I was alluding to in the first part of the talk, was just this misperception that continues, that for women, that if your factor levels are normal, that is not possible for you to have a bleeding tendency. So if you have bleeding symptoms and you know that you are a hemophilia carrier, if you're not getting the care that you need from a doctor, you need to advocate and find somebody who understands your disease. One great resource is the Foundation for Women and Girls with Blood Disorders, has a website with a map of women's clinics that are dedicated to women with bleeding disorders. I'm sure HFA also has, lists of HTCs. Like, keep going. Don't be satisfied with the doctor if you feel like they're not giving you the right information, because what I've learned from my experience is that, families living with these diseases, you are experts as well, and you may know more about the disease than the provider that you're seeing.
All right, I have a question, and I don't know if you're the person to ask it, but is there a greater risk for miscarriage or in utero death for a woman with a bleeding disorder? Is that something she has to worry about? Oh, you're muted.
Is that better?
Yep, there you go.
Okay. Yes, that's a common concern that patients have. And there is not strong evidence that women with bleeding disorders have more difficulty getting pregnant, nor is there an increased risk of miscarriage. Sometimes that gets confused with women who have clotting disorders, who are, their families are prone to blood clots. Those families can have issues. So for women with bleeding disorders, it's more about, they are more prone to bleeding during the pregnancy, but not necessarily miscarriage.